So I promised that just briefly tell you about the genes and environment. Time and again, you heard from your doctors that MS is from a combination of getting the wrong genes and the wrong environment. So we know this. But what are the wrong genes? 20 years ago, MS Society of Canada funded this phenomenally big project, which is still ongoing, and a lot of good has come from it. But at the beginning, we were under the naive impression that in a decade or so, we'll know exactly that these 5 genes cause MS, and this is what they do, and this is how we can cure it, and so on. And maybe I was naive at that time. But we now know that it's not 5 or 6 genes, it's dozens, if not more genes. And we don't know how they interact. And one gene that is known to be increasing your risk of developing MS is this HLA-DRB1. And then another gene in a similar part of the genetic complex is called HLA-A2. It actually is protective. So that's the gene angle. Not a whole lot, but a couple of genes, what increases your risk and one decreases your risk. And amongst the environmental factors, we know viruses, climate, toxins, nutritional things have been blamed. Vitamin D story is still evolving. I strongly believe in it. You all should be on vitamin D, at least 2,000 IUs a day. Done my vitamin D pitch. The Epstein-Barr virus, there's an association with MS prevalence, and smoking is getting to be a big risk factor too. So in the next slide, I'm going to show you something that I found at least interesting. So remember the bad gene. Well, what does it do? What kind of a risk does it impart to the public in getting MS? Well, the odds ratio is about 3, so you're 3 times as likely to get MS if you have this gene. What if you get the HLA-A2 gene, the protective gene? Odds ratio is 0.5, so you have a 50% less risk of getting MS if you have that gene. Now, genes were dealt with. We have no choice in making them, but that's just to show you that. And the smoking increases your risk of MS by about 1.5 to 2 times. And what was astounding to me was that these researchers from Sweden have done an analysis, and what they showed was that smoking is associated with this high-risk gene and associated with you not having the low-risk gene. Therefore, when you have the triple combination of smoker, bad gene, and not the good gene, your odds ratio is 13. So 13 times the risk of developing MS. That's very high. And the reason I'm bringing this up is because I have a feeling that instead of having these ideas about that we'll come up with the exact genes that cause MS, which may happen, but I don't know when. But for the moment, I think if information like this comes out and we know which environmental factor interacts in what way with the genes and gives you what risk, we can then say with certainty that you ought not to smoke. Well, it's smoking, it's an easy thing to say because it's bad for you for other reasons. But I'm talking about other environmental things that we may have a similar data on in the next year or two. There were many studies on exercise in multiple sclerosis. I mean, we all know exercise is good for you. But has it been studied? Has it been studied well? And I just chose a couple. One is an Irish study from University of Limerick. Their aim was to look at, does it matter whether you get one-on-one therapy with a physiotherapist or if you're in a group getting physiotherapy? So as you can see, 110 patients were randomized. Again, power of randomization. Let a computer decide which way patients go. And so some of them got the group therapy, so there were 6 in a group, and there was 1 trainer with them, and some of them got randomized to one-on-one physiotherapy. In the end, at the end of that 10-week period, they had 83 patients who had completed the course. 48 were in the group therapy, 35 in the individual physiotherapy. These patients all filled out some valid questionnaires on fatigue, quality of life, and so on. And there was a significant improvement in both groups compared to their baseline. So exercise is good. The limitation is that there was no control group. So both groups got exercise one way or the other. But at least we can say that it works equally, doesn't matter, group setting or one-on-one. And sometimes I see a patient in my office and not too keen go into an exercise physio class somewhere, but would like one-on-one. But this can reassure you that exercise in any setting is good. The other study was from Iran, kind of an interesting study. 30 females with mild MS. So these are patients who are actually walking and even running. And they're divided into three groups. Group A was just waitlisted. So they didn't get any exercise or any formal exercise program. They were allowed to do what they did. And remember now, these are generally young, probably working females, so they did their usual things that they do over that period of time. Group B got aerobic exercise, so probably treadmill and running and so on. And Group C got isometric or weight training. And again, questionnaires were done before and after. And in this group, clearly, the two groups, the B and C groups, had significant improvement compared to the one that was left waiting to get exercise. They weren't inactive, they were doing their usual things. So the point here is that usual things may not be enough. Get out there and exercise. So the conclusion was that exercise helps, all types of exercise, whether it's aerobic or otherwise. I have a couple of final slides now. So this one is the timeline that shows you what we have at the present time. The vertical line at the right end of the slide is a black line. That's the year 2010. That's where we are now. Fingolimod has been approved in US, should be available in Canada in the next 6 months to a year. And then cladribine, teriflunomide within 18 to 24 months, and then the others in the 2 to 5 year range. So therefore, these are all a reality in the next 1 to 5 years. So to conclude, for relapsing remitting MS, there will be many new drugs available that will change the treatment landscape in the next 1 to 5 years. In 5 years' time, I predict there will be definitely 5 new drugs on top of the 5 that we have, so we'll have 10, and most of the new ones will be oral. New drugs are clearly better, seemingly, but they have possibly higher risks. Certainly, we don't know what the safety is long term. The challenge will be to look at a patient and say, for you, this particular agent is the best for you. So how do we individualize therapy? And this opens up a new area of research called biomarker research to try and find out how do we categorize patients and how do we target individual therapies. The current drugs, for all their limitations, probably still will be around in those next 5 years. They're clearly there because they have proven efficacy and they are safe. So they'll continue to play a role, but I have a feeling that after 5 years, they'll start to fizzle out. Secondary progressive MS and primary progressive MS remains a major challenge for us. And in the end, don't forget about exercise. Group, single, aerobic, anaerobic. It's for you. Thank you.